Now let's continue with a high-yield subject, which are aneurysms. So next to this title, we have a nice little phrase in the book that says, localized pathologic dilation of the aorta. Now obviously this can cause pain, which can be a sign of a leak in the aneurysm, a dissection, or imminent rupture. Sounds great. Well, we know that an aortic aneurysm is obviously a dilation of the aorta, but why does the dissection or leak cause pain? Well, the leakage of fluid or blood associated with the rupture can irritate the abdominal aortic plexus. Remember, there are a bunch of veins and arteries, but in addition to that, it's neurovasculature, right? So here's our abdominal aorta. We have our celiac trunk and SMA and IMA and all that stuff coming off. And there's an integrated network of a plexus of nerves that wraps around all of these. And obviously, if you distend this layer, then you're going to have stretching of these nerves and you can have incredible amounts of pain. In addition to that, for example, in a situation where there is rupture, blood is very caustic and you will have accumulation of blood in the retroperitoneum, and that will directly irritate some of the nerves. Now, what about an abdominal aortic aneurysm? Here is a sagittal view, similar to the one that you might see on your Step 1 exam. Yes, looking at this sagittal view of the abdominal aortic aneurysm is fair game. As you can see, there is something right here that doesn't look very normal. So, male smokers over the age of 50 are the classic patient population that you worry about. And when I say you need to worry about it, I mean look for that in your vignette. So, as a matter of fact, you automatically start doing ultrasounds on any male that has ever smoked and is over the age of 65. So, one hit of cigarette, over the age of 65, you're going to get an ultrasound. Not trying to encourage you to lie to your doctor if you've ever smoked or not, but that is the screening because these things are a big deal. Now, what happens is that, as you can see here, there's like the renal artery bifurcating off the abdominal aorta. So the abdominal aorta below the level of the renal arteries is particularly susceptible because there is no vasa vasorum within the adventitial layer of the artery. Remember, there's the intima, the media, and the adventitia, and the vasa vasorum is just within the adventitia, and it helps supply blood to this area and also the outer layer of the media. While the inner layer, the intima, and the innermost layer of the media are supplied by diffusion from the blood that is within the lumen. So in the situation below the renal arteries, there is no vasa vasorum. So blood must supply oxygen and nutrients via diffusion for all of these layers, as opposed to above the renal arteries where there are vasa vasorum providing blood to the adventitial and outer media. So how does that increase our risk for an aneurysm? So we just drew these layers with the adventitia, the media, and the intima. In the situation that we have an atheromatous plaque, somewhere here in the intima, it increases the distance that the oxygen and nutrients must travel to diffuse. We are setting up those tissues that are farthest away from the lumen, which are the adventitia and the outer layer of the media, including the external elastic lamina, for ischemia. You guys all know that ischemia of structures within a vessel will probably weaken it because you are losing tissue strength because that tissue is dying due to hypoxia and inappropriate diffusion of nutrients to the tissue and away from the tissue. So what about the intima? It somehow has to become weak because we need dilation of all three layers, right? That is a true aneurysm, not a false one, a true one. So remember, with the atheromatous plaque just chilling in the intima here, there's our intimal layer, and there's a plaque with the fibrotic cap in there. Remember, there are macrophages that initially came into the intima, and they phagocytized that oxidized LDL. They became foam cells. So even though they cannot break down this oxidized LDL, that doesn't mean that they can't continue to function. They will continue to function, taking in LDL into the point where they explode, and they release all of their contents, including cytokines. Okay, we get the point, man. The point is that these cytokines are liberated from within the macrophage. There are some particularly bad ones, and they're really bad ones that induce matrix talloproteases to work. And this leads to the degradation of collagen, elastin, and proteoglycans. And if you have this kind of tissue activity in your intima of cellular enzymes that break down tensile strength by breaking down collagen, breaking down elastin, breaking down proteoglycans, you can guarantee you're going to have weakening of that layer. So now we have weakening of the intima due to degradation of these structures, weakening of the media due to hypoxia and a decrease in nutrient diffusion, and we also have a decrease in the adventitial layer. This sets us up perfectly for a weakening of all three layers, and all three layers is required for a true aneurysm. So, what is the difference between an abdominal aortic aneurysm and a thoracic one? Well, AAA, which is an abdominal aortic aneurysm, is mainly associated with atherosclerosis and smoking, right? Makes a lot of sense, right? Because both of these structures lead to the formation of atheromatous plaques. We lack vasa vasorum below our renal arteries. Our abdominal aorta is particularly susceptible to the risk factors associated with the formation of an aneurysm that are atherosclerosis and smoking, because these directly affect the integrity of those three layers and the ability of oxygen and nutrients to diffuse through those three layers of the vessel, as opposed to the thoracic aorta. So again, atherosclerosis and smoking mainly progress to intimal damage by accumulating plaque and limiting oxygen and nutrient diffusion, as opposed to the thoracic aorta, which aneurysms are mostly associated with weakness of the thoracic wall due to an intrinsic defect of the structure within the layers of the vessel wall. Particularly for thoracic aortic aneurysms, we're talking about something like Marfan's or tertiary syphilis or chronic hypertension, where that thoracic aortic element is just taking a pounding with high pressure over time. Now let's talk about thoracic aortic aneurysms a little more in depth. Let's look at this CT scan. The image is showing us an ascending aortic aneurysm that just happens to have a dissection shown by this arrow. As you can see, this seems like there's some sort of integrity, and then this kind of is a ruffled edge. So you see a lot of this in, again, our Marfan's patients because they have abnormal fibrillin. Remember, this is a protein that is responsible for acting as a scaffolding for our tropoelastin, which is right here, that's the little tick marks, and then tropoelastin gets cleaved into elastin. If you have an abnormal structure, which is this element here, fibrillin protein, which is definitely the case in some Marfan's patients, not all, because some of them have an abnormal, chronically activated transcription growth factor beta receptor. But the main point here is that we cannot adequately build elastin elements because of the defective fibrillin that is supposed to act as our scaffolding. Now, where in the aorta is elastin crucial? Media. Media is this very strong element. It is distensible, and that is mainly because it's supposed to have lots of elastin. So remember, we said abnormal fibrillin is unable to limit the signaling of transcription growth factor beta. Too much TGF-beta means that we tell fibroblasts to make tissue all the time, in addition to limiting the matrix metalloproteases that are supposed to help regulate some of the tissue turnover so that we always have healthy, viable tissue. So we just start tacking on collagen, glycosaminoglycans, and elastin at uncontrolled rates. This causes a very weak and floppy layer within the media, and it can also be seen anywhere where these structures are, where elastin is supposed to be, such as on heart valves. And we have this very popular term that people like to throw around with the cystic medial degeneration. The deposition of gelatinous glycosaminoglycans among irregular elastin fibrils in the media kind of explains how someone came to include the name media, which tells us where this is happening, and then obviously degeneration because the tissue is not normal, and there's some cysts because the fact that you can actually have accumulation of fluid because glycosaminoglycans are very electronegative and will attract high levels of water. Let's discuss what is actually happening on a histopathologic level. So, instead of elastin fibers running in parallel, like so, they all bunch up like this. And the excess glycosaminoglycans that is interspersed within these irregular elastin fibrils leads to the appearance of cysts within these irregular elastin. So again, this leads to the appearance of these cysts within a very disorganized elastin background in the media. So we have cysts in the media, and it looks like the tissue is degenerating, because in fact it kind of is. There's just way too much of it being deposited, whereas irregular, there's no ability to turn over the tissue because we're inhibiting our matrix metalloproteases, and there's just uncontrolled fibroblast signaling. So the pathology is cool and all, but why is this a problem? Obviously, this is not very strong arterial tunica media. So because we do not have an organized architecture, we just have a bunch of nonsense. It's just accumulated, disorganized fibrils of elastin. Eventually the tissue will just degenerate, which is where we get the final part of the name. This obviously predisposes us for rupture because there is no structural integrity and strength to the media, which is supposed to be the strongest layer. How does hypertension predispose us for an aneurysm? So this person does not have Marfan's, they just have really high blood pressure all the time. This is a really definitely easy one for us to understand. Again, we have the intima, this is the internal elastic lamina, the media, the external elastic lamina, and the adventitial layer. The chronic high pressure will not only damage large vessels, but it will also destroy the tiny vasa vasorum that are within the adventitial layer. The vasa vasorum is responsible for supplying the adventitial tissue with blood and nutrients and the outer layer of the tunica media. So we'll divide that here. This is the inner layer, this is the outer layer. Remember, we said that hypertension causes endothelial cell damage and subsequent reactive collagen deposition and vascular smooth muscle cell proliferation. So then that's exactly what's going to go on in these little vessels of the vasa vasorum that sit here in the adventitial layer. So even though this is an adaptive response, the extra collagen and proliferation of vascular smooth muscle cells within our vasa vasorum in response to chronically high levels of blood pressure, it continuously narrows the lumen to the point where we just start obliterating these vessels, and the lumen is so small that there's such low blood flow through these vessels that there will be downstream hypoxia of what it's supposed to supply. That makes a lot of sense, right? It's supposed to supply these structures. And that means that these layers start to die. The adventitia and the outer layer of the tunica media will become weak. Now, how else can we get that problem? Tertiary syphilis. Tertiary syphilis does the exact same thing, except that these tricky little spirochetes, or Treponema pallidum, they actually reside in the vessel wall of those vasa vasorum. So, these guys like to just live within those tiny vessel walls that are within the adventitia and the outer layer of our thoracic aorta. So this is an electron micrograph of a biopsy taken from the vasa vasorum of the thoracic aorta. These spirochetes are actively residing within the vessel wall. Our immune system sees that there are spirochetes in the vasa vasorum and doesn't like that one bit. What is the immune system going to do? It's going to generate antibodies against these guys. The antibodies will deposit all in these vasa vasorum and hope to clear the spirochete out. The problem is that there's collateral damage, and the collateral damage is the actual vessel wall itself. So we deposit antibodies all in the vasa vasorum. So these are antibody complexes, and they're bound to the antigen, which is obviously the spirochete antigen. And there will be activation of the immune system within the vasa vasorum. What is that bad for? It's bad for the outer layer of the media and the adventitial layer, because that is how they get their nutrients. Remember, blood, this is our lumen here, and blood can diffuse oxygen and nutrients to the intima and the inner layer of the media. So this tertiary syphilis presentation is particularly risky for an antibody-mediated damage to these elements. The immune system does not care that it might damage the vasa vasorum. Number one objective is to attack the spirochetes even though collateral damage will occur. The process of inflammation and healing by fibrosis obliterates the lumen of the vasa vasorum. These are very small caliber vessels. And this makes a lot of sense why they named this process obliterative endarteritis, because we're obliterating the lumen of these very small vessels, and endarteritis indicates there's inflammation of the inner lining of an artery, which is exactly what is happening when our immune system sees those antibodies localizing to the spirochetes within the wall of the vasa vasorum in the adventitial layer of the thoracic aorta. So why do we need to be worried about a thoracic aneurysm? Obvious answer to that, but let's continue and discuss why. Aortic dissection.